Welcome to the deep dive. Today, we're taking a focused run through some key concepts, musculoskeletal disorders, and, well, the whole complex issue of fatigue.
That's right. And we're grounding everything purely in Chapter 49 of Porth's Pathophysiology.
Our mission is really to pull out the core mechanisms, the how it works or how it breaks apart behind these conditions.
Exactly. We want to give you a clear framework. Think skeletal growth gone wrong, adult bone maintenance failing, and then tackling activity intolerance and fatigue.
So we basically got three main areas: skeletal growth and development issues, then metabolic bone diseases, and finally, activity intolerance and fatigue. Let's kick things off right at the beginning, how bones get built.
Okay, so first we absolutely have to distinguish between bone modeling and bone remodeling. They sound similar, but they're quite different.
Modeling first, then? What's that about?
Modeling is like the initial blueprint and construction of your skeleton. It forms the macroscopic shape, the overall structure. And it basically stops once you reach maturity, say around 18 or 20 years old.
Right, so that's building the house. And remodeling is?
Remodeling is the lifelong maintenance, constant upkeep. It's this really elegant coupled process. You have osteoclasts, think of them as the demolition crew resorbing old bone. And then immediately osteoblasts, the builders come in and lay down new bone. They work together.
And the key problem later in life is?
Well, the key insight, especially from metabolic bone disease, is that with aging, that coupling gets weaker. Resorption starts to outpace formation. The demolition crew works faster than the builders can keep up.
Ah, okay, so net bone loss.
Net bone loss, that's the crux of it.
And in childhood, the engine driving that linear growth, getting taller, that's the epiphyseal growth plate, right? How vulnerable is that structure, really?
Oh, it's incredibly vulnerable. Probably the most vulnerable part of a growing skeleton. It's this zone of nonstop activity. Cartilage synthesis, calcification, erosion, bone invasion.
So super active metabolically.
Exactly. Which means trauma, like a fracture that separates the epiphysis, can easily tear the blood vessels feeding it.
And the consequence.
If that blood supply is cut off, growth can just stop right there, leading to a permanently shorter limb.
Wow. And we also see that vulnerability connected to nutrition, which kind of gives us a window into how bone matrix is built.
It really does.
Yeah.
You can think of bone having two main components. If you lack vitamin C, scurvy, you can't form the organic matrix properly. The scaffolding is weak.
Okay.
But if you lack vitamin D rickets, the scaffolding might be laid down okay, but you can't mineralize it properly. You can't harden it with calcium, so the bone becomes soft.
That makes sense. Two different problems. What about when the fundamental material, the collagen itself, is defective from the start, like in osteogenesis imperfecta?
Right. OII, or brittle bone disease, that's usually a hereditary issue, typically autosomal dominant. The problem is defective type I collagen synthesis. Collagen is like the steel rebar in concrete.
And in OI?
In OI, the rebar is faulty, really faulty, so you get extreme skeletal fragility, multiple fractures from minor trauma or sometimes no trauma at all, thin skin too, and often those characteristic blue or gray sclerae, the whites of the eyes, look bluish.
Is there a particularly severe type?
Yes, type 3 OI is known as the progressively deforming type among those who survive infancy. It's very serious.
Then there are mechanical alignment issues, like developmental dysplasia of the hip, DDH.
Yes, DDH isn't about the bone material itself, but the joint stability. It's a spectrum, from just a bit unstable to the femoral head being partially out of the socket subluxed or completely out dislocated.
And it's more common in certain groups.
Tends to be more common in firstborn babies, girls, and often the left hip. We think intrauterine positioning plays a big role.
How do you pick it up early?
In newborns, it's all about the clinical exam. We use specific maneuvers, the ortolani, which checks if a dislocated hip can be gently popped back in, often with a palpable clunk. And the Barlow maneuver, which does the opposite, it checks if a located hip can be gently pushed out of the socket. Tells you about instability.
And finding it early is critical for treatment.
Absolutely critical. Intervention before 6 months, often with something like a Pavlik harness, which holds the hips in the correct position, gives the best chance for the hip socket to develop normally.
Right. And another common one is clubfoot.
Congenital clubfoot, or Talipes equinovarus. Yeah, pretty common, maybe 1 or 2 per 1,000 births. The foot is pointed down, plantar flexed, and turned inwards, kind of like a horse's hoof, hence the equino part.
Treatment for that?
Thankfully, non-operative treatment is usually very successful. The Ponseti method involves gentle, weekly manipulations and casting to gradually correct the position. Works really well.
Okay, so we've covered some foundational growth issues. Let's pivot now to a specific group of conditions in kids, the juvenile osteochondroses. These seem to hit those active growth centers.
Exactly. These conditions really highlight the stress points in a growing skeleton. Three main ones stand out. First, Legg-Calvé Perthes disease.
What's happening there?
Essentially, it's osteonecrosis, bone death of the top part of the femur, the femoral head, specifically the epiphysis. The blood supply gets interrupted. For reasons we don't fully understand, it's idiopathic.
So the bone tissue dies, then what?
Well, the body slowly absorbs that dead bone and replaces it over maybe 2 to 3 years. It goes through predictable stages of vascularity, revascularization, reossification, and finally healing.
And how does that show up in a child?
Often as hip or groin pain, but sometimes the pain is referred to the thigh or even the knee, or maybe just a painless limp, and they can't rotate their hip inward very well.
Prognosis.
Generally better the younger the child is when it starts. Younger kids have more potential for the bone to remodel back into a good shape.
Okay. Next one.
Osgood-Schlatter disease. This one is super common in active, growing adolescents, especially those playing sports involving running and jumping.
Ah, the classic knee pain one.
That's the one. It's basically microfractures or inflammation, where the patellar tendon, the big tendon below the kneecap, attaches to that bony bump on the shin, the tibial tubercle.
So repetitive strain.
Exactly. Causes pain right at the front of the knee, swelling, and that tibial tubercle becomes more prominent, sometimes quite tender.
But it gets better.
Yeah, the good news is it's self-limiting. Once the growth plate there closes, usually in the mid to late teens, the pain resolves.
Okay. And the third one sounds more serious. Slimped capital femoral epiphysis, SCFE.
It is more serious, definitely requires urgent attention. SCFE happens right around the time of skeletal maturity, often in adolescents who are overweight.
And what exactly slips?
The ball part of the hip joint, the proximal femoral epiphysis, literally slips off the neck of the femur. Usually displaces downwards and backwards, kind of like ice cream sliding off a cone.
Ouch. How does that present?
Often with groin or thigh pain, but frequently it's referred pain to the knee, which can be misleading. They'll have a limp difficulty walking.
And the treatment needs to be quick?
Immediate. The child needs to stop bearing weight on that leg right away. Then it requires surgery, usually pinning the epiphysis in place, in situ fixation, to stop it slipping further and prevent really severe lifelong hip problems like arthritis or even a vascular necrosis.
Right, critical intervention there. Okay, let's transition now from growth issues to problems with maintaining bone structure in adults. Let's talk metabolic bone disease.
Yeah, and what's really interesting here is how these conditions relate back to that remodeling process we talked about earlier, that balance between resorption and formation.
So start with osteopenia and osteoporosis. How do they differ?
Well, osteopenia isn't really a diagnosis in itself. It's more of a description. It just means bone density is lower than expected for your age and sex, but not low enough to be osteoporosis. Think of it as a warning sign.
And osteoporosis.
Osteoporosis is a disease. It's defined by a significant loss of mineralized bone mass. This makes the bone much more porous, weaker, and dramatically increases the risk of fracture, even from minor stress.
How's it diagnosed definitively?
Diagnosis relies on bone mineral density testing, usually a DESI scan. The results are given as a T-score, which compares your density to that of a healthy 30-year-old adult. A T-score of -2.5 or lower indicates osteoporosis.
And the underlying mechanism is that imbalance again.
Exactly. Bone resorption consistently outpaces bone formation. And peak bone mass, which you achieve in young adulthood, is a huge factor. Genetics play a role, but so do exercise, nutrition, and hormones.
You mentioned hormones. Postmenopausal osteoporosis is the most common type, right?
By far. The key driver there is estrogen deficiency after menopause. Estrogen normally puts the brakes on osteoclast activity, the bone breakdown cells.
How does it do that?
It involves a complex molecular pathway, RANKL, and OPG. Basically, estrogen helps maintain a balance that favors less resorption. When estrogen levels drop, osteoclasts become more active and bone loss accelerates, especially trabecular bone, the spongy bone inside vertebrae and at the ends of long bones.
So the internal structure weakens first.
Precisely. Which is why it's often called a silent disorder. People usually don't know they have it until something breaks.
Like what kind of fractures?
The most common are vertebral compression fractures. The spinal bones just kind of collapse or wedge down. This causes back pain, loss of height, and that characteristic forward curvature of the upper spine, the kyphosis or dowager's hump. Hip fractures are also very common and debilitating.
Prevention and treatment.
Prevention focuses on building maximum peak bone mass when young, adequate calcium, vitamin D, weight-bearing exercise. Later in life, maintaining calcium, maybe 1,500 mg a day post-menopause, and vitamin D, around 400, 800 IU day, is crucial. And regular weight-bearing exercise remains important.
And medications.
Yes, pharmacologic treatments often involve anti-resorptive drugs, like bisphosphonates, which slow down the osteoclasts. There are also some anabolic agents that stimulate bone formation.
Okay, now we need to really clearly distinguish osteoporosis from osteomalacia and rickets.
Absolutely crucial distinction. Osteoporosis is about loss of bone mass. The bone becomes brittle and thin. Osteomalacia and rickets are about bone softening. The amount of bone matrix might be normal, but it's inadequately mineralized. It hasn't hardened properly.
So same matrix, but it's soft instead of strong.
Exactly. Rickets is the term used in children, whose growth plates haven't fused yet. Osteomalacia is the adult form.
And the cause usually?
Most often it's due to vitamin D deficiency or problems with vitamin D metabolism. Vitamin D is essential for calcium absorption and bone mineralization. Phosphate deficiency can also cause it, but that's less common.
What does rickets look like in a child?
Because the bones are soft, they tend to deform under stress. You might see widening at the ends of long bones, bowing of the legs once the child starts walking, maybe delayed closure of the fontanelles, soft spots on the skull. Sometimes you see bead-like bumps along the ribs, the rachitic rosary, maybe a sway-back posture, lumbar lordosis.
Right. Okay, one more metabolic bone disease. Paget disease.
Paget disease, or Osteogenesis deformans. Second most common after osteoporosis. This one's quite different. It's characterized by focal areas, specific spots in the skeleton, where bone turnover goes absolutely haywire.
Haywire how?
You get excessive bone resorption by abnormal osteoclasts, followed by frantic, disorganized bone formation by osteoblasts. It's just chaotic remodeling.
So lots of activity, but it's messy.
Very messy. The new bone that's laid down is structurally weak, disorganized, and enlarged. Pathologists describe a characteristic mosaic pattern under the microscope. It's poor quality bone.
And the symptoms depend on where this is happening.
Exactly. If it's in the skull, you might get headaches, tinnitus, even hearing loss as the bone encroaches on nerves. In the spine, it can cause kyphosis or nerve compression. In the legs, like the femur or tibia, it can lead to bowing and a characteristic waddling gait. Pain is common.
Is there a particularly serious complication?
Yes, the most serious potential complication, especially with extensive disease, is actually cardiovascular.
Yeah.
Those highly active pagetic bone lesions are very vascular. They have a rich blood supply. The heart has to work much harder to pump blood through all this abnormal bone tissue,
Leading to
high output heart failure in some severe, long-standing cases.
Wow. Okay. That covers the major metabolic bone issues. Let's switch gears completely now and talk about something more subjective but equally debilitating. Activity intolerance and fatigue. How do we define these?
Good question, because they're related but distinct.
Oh.
Activity intolerance is more objective. It means you literally don't have sufficient physiological or psychological energy reserves to endure or complete required or desired daily activities.
Yeah.
You just can't do it.
And fatigue.
Fatigue is the subjective sensation of that state. It's feeling exhausted, like your energy reserves are totally depleted. The crucial difference from just being tired is that fatigue often persists despite adequate sleep or rest. Normal tiredness goes away with rest. Fatigue often doesn't.
And we can distinguish between acute and chronic fatigue.
Yes. Acute fatigue usually has a rapid onset. It might be normal muscle fatigue after strenuous exercise, or the fatigue that comes with an acute viral or bacterial infection. It serves a purpose, often protective, and it typically resolves once the activity stops or the infection clears.
Makes sense, like feeling wiped out after the flu.
Exactly. Or think about someone who's been on prolonged bed rest. They experience fatigue disproportionate to activity because their muscles are deconditioned. That's also a form of acute fatigue related to a specific cause.
But chronic fatigue is different.
Very different. It's much more complex, lasts longer, often for months or years, and isn't relieved by rest. It's frequently associated with underlying chronic health conditions, think cancer, heart disease, autoimmune disorders, anemia, depression. It severely limits activity and really impacts quality of life.
And there's an important point in the text about the psychological aspect.
Yes, this is critical. For people with debilitating chronic fatigue, the associated anxiety or depression is often a consequence of the illness and its limitations, not the primary cause of the physical exhaustion. The fatigue came first, impacting their life. leading to distress.
That's a really important distinction for understanding the patient's experience, which leads us to myalgic encephalomyelitis chronic fatigue syndrome, MECFS.
Right. MECFS is defined as profound, disabling fatigue that has lasted for at least 6 months. It's often accompanied by a whole constellation of other nonspecific symptoms like cognitive difficulties, brain fog, sleep problems, muscle and joint pain.
And diagnosis is tricky.
Very tricky. There are no definitive diagnostic biomarkers, no specific lab test. So diagnosis is usually made based on the clinical picture and by carefully excluding other potential medical or psychiatric conditions that could cause similar symptoms.
What are the core requirements for diagnosis, based on the CDC criteria mentioned?
There are 3 main required symptoms. First, a substantial reduction or impairment in the ability to engage in pre-illness levels of activity, accompanied by that profound fatigue, lasting 6 months or more, and it's not the result of ongoing exertion and isn't substantially relieved by rest.
Okay, that's the core fatigue component. What else?
Second, and this is really a hallmark symptom, post-exertional malaise, often called PM. This means symptoms get significantly worse after physical, mental, or even emotional exertion activity that wouldn't have caused problems before the illness.
And this worsening isn't just feeling more tired.
No, it's often a flare-up of multiple symptoms, increased fatigue, pain, cognitive issues, flu-like feelings. And crucially, this PM can be delayed in onset and can last for days, weeks, or even longer. It's a defining feature.
Right, that disproportionate payback after activity.
Oh, and the third criterion.
Unrefreshing sleep. Patients wake up feeling just as tired, or sometimes even more tired, than when they went to bed, regardless of how long they slept.
So fatigue, post-exertional malaise, and unrefreshing sleep are the essentials. Those 3 are required for the diagnosis, along with ruling out other causes. Often there are other common symptoms too, like cognitive impairment or orthostatic intolerance.
And treatment, given the unknown cause.
Because we don't know the exact cause or mechanism, treatment is currently focused on managing the symptoms and improving function and quality of life. It's about supportive care.
Like what?
Things like helping manage pain, addressing sleep disturbances. A key component is activity management, sometimes called pacing. This involves helping patients learn to balance rest and activity to try and avoid triggering that post-exertional malaise. It's definitely not about pushing through the fatigue.
So finding that individual energy envelope.
Exactly, finding their limits and respecting them. Emotional support and coping strategies are also vital, given how debilitating and often misunderstood this condition is.
Okay, so wrapping this all up, what's the big picture here?
Well, we've really journeyed across the lifespan, haven't we? From the fundamental processes of bone modeling and remodeling to things going wrong during growth, OI, DDH, the osteochondroses. Then we saw how bone maintenance can fail in adulthood with osteoporosis, osteomalacia, Paget's. And finally, we looked at that systemic failure of energy regulation in fatigue and MECFS.
And the thread connecting them all is?
It's understanding the underlying pathophysiology, linking the mechanism, whether it's faulty collagen, poor mineralization, estrogen loss driving osteoclast activity, or maybe immune dysregulation in MECFS, though that's still being researched, linking that mechanism to the clinical signs and symptoms you actually see in a person. That's the core of it. Seeing how a slipped epiphysis leads to knee pain, or how disorganized bone and Paget's can stress the heart.
It connects the micro level to the macro experience.
Precise.
So as we finish, here's something for you, our listeners, to think about. We've seen repeatedly how vital weight-bearing physical activity is for building peak bone mass early on, for maintaining bone density later, and even as a carefully managed tool in chronic fatigue to improve endurance within limits. Given all that, how might our modern, often very sedentary lifestyles be fundamentally challenging our body's built-in systems for skeletal maintenance and overall resilience against these kinds of disorders? Something to mull over.
Yeah, definitely food for thought. Well, thank you for diving deep with us today into these aspects of musculoskeletal health and fatigue from Porth's. We hope breaking down these mechanisms has been helpful.
Absolutely. Until next time, keep digging deeper.